Good afternoon and welcome to the launch of the Acute Anaphylaxis Clinical Care Standard. My name is Amanda Walker. I'm a Clinical Director at the Australian Commission on Safety and Quality in Healthcare here in Sydney, and I work as a palliative care doctor in the Southern Highlands of New South Wales. I'd like to start by acknowledging that I'm hosting this webcast from the lands of the Gadigal people of the Eora Nation, and I pay my respect to elders, past, present and emerging. I know we're joined today by people all over Australia, so I would like to acknowledge the traditional custodians of the various lands on which you all work, and the Aboriginal and Torres Strait Islander people participating in this webcast. We are delighted to be launching the Acute Anaphylaxis Clinical Care Standard today, and we have a great panel who will join me to discuss what this means for providing care to people with or at risk of anaphylaxis, and why this new standard is so important. But first, I have a short presentation to introduce the standard. The clinical care standard we launched today has a large footprint. More than 4 million Australians live with allergies. Allergies are common, but this can desensitise us to the fact that some of these people may experience anaphylaxis, which is a life-threatening condition. People at risk of anaphylaxis are vulnerable at all times. Anaphylaxis is characterised by a sudden onset and things can escalate very rapidly. Anaphylaxis is a life-threatening condition. Fatalities are rare but tragic. Some of the common factors in preventable deaths have been delays in administration of adrenaline, positioning that compromises circulation, and failing to recognise that a person, even if they appear to be okay when they're at triage after an earlier dose of adrenaline, may still be at risk. What you do matters. Preventable deaths of this kind shine a light on the areas of clinical practice where our performance could improve. The extreme vulnerability of people at risk of anaphylaxis means that we must always keep anaphylaxis front of mind. You will protect the vulnerable, you may save a life. Allergies occur when a person's immune system reacts to substances that are often quite harmless to other people. These substances are known as allergens. Stings and bites, medicines and food are common allergens. Up to 10% of all infants and 2% of adults have food allergies. But allergens can be anywhere and just about anything. Sometimes people have very limited control over their exposure to a known allergen. Sometimes the allergen is unknown. An allergic reaction can be triggered by any food, food additives, latex or even bodily fluids, hormones or unusual causes like temperature change. This standard is particularly dear to me as I'm allergic to cold. You would think that living in the Southern Highlands of New South Wales would be my greatest risk, but our homes are built for warmth and the invention of the electric throw rug is a blessing indeed. But my greatest risk is actually in the height of summer, when I'm swimming or when I'm in a relentlessly air-conditioned space like a shopping centre or a cinema or taxis or even hospitals. People with anaphylaxis can find themselves vulnerable at any time. The incidence of anaphylaxis is increasing. In the last 5 years, there's been a 35% increase in public and private hospital admissions with anaphylaxis and a 51% increase in public hospital emergency department presentations, with a 6% increase in emergency presentations in the past year alone. There are well-recognised Australian guidelines for the management of acute anaphylaxis. Despite this, research shows that recommended care pathways are not always adhered to. A study in 8 Australian emergency departments found that 27% of reactions consistent with anaphylaxis were not given adrenaline. An analysis of 324 anaphylaxis fatalities between 1997 and 2013 highlighted delays in treatment with adrenaline. This level of risk and the preventable deaths we've seen in recent years are not acceptable, especially when anaphylaxis is treatable. People who are at risk of anaphylaxis should feel safe at all times. We're here today to make sure they do. We developed the clinical care standard for acute anaphylaxis to address these areas where an improvement in clinical practice is required so that we can help keep people safe and reduce preventable deaths. The Acute Anaphylaxis Clinical Care Standard has been endorsed by relevant clinical colleges, professional societies and consumer groups, in particular the Australasian Society of Clinical Immunology and Allergy, or ASCIA, Allergy Australia and Allergy and Anaphylaxis Australia. It supports the delivery of safe, high-quality, evidence-based clinical care. It focuses on areas where we know we can shift the dial on quality care and is relevant across all settings, wherever people are. The Acute Anaphylaxis Clinical Care Standard does not include a detailed assessment of allergies in general or their management, and it also doesn't cover the management of anaphylaxis in patients in operating theatres and intensive care units where specialised clinical expertise and hemodynamic monitoring is available. The Clinical Care Standard is structured around a series of quality statements that promote early recognition, prompt treatment, and responsible discharge of patients with anaphylactic reactions. It covers the period from when a patient first arrives at a doctor's surgery or their first clinical contact in the community when a paramedic arrives or on arrival at the hospital, going all the way through to when they are discharged. Each quality statement is considered from the perspective of the patient, the clinician, and the health service. The 6 statements have equal significance and relevance, but we're going to draw your attention to 3 of them now ahead of our panel discussion. Intramuscular adrenaline injection is the first line of treatment. Treatment delays can cause symptoms to progress to life-threatening very rapidly. If you suspect anaphylaxis, act and treat now. Choose intramuscular adrenaline injection ahead of puffers, antihistamines and steroids. There are no contraindications to administering intramuscular adrenaline injections in the context of anaphylaxis. Again, it's delays that cause harm. Prompt administration of adrenaline can stop the progression of life-threatening symptoms, and so even in hospitals, we need to ensure access to personal adrenaline injectors. We do acknowledge that this represents a significant change and that health settings traditionally have limited patient access to medications for very good reasons, but this is the one exception. Patients may need to self-medicate to save their life. It's important to note that this is now standard procedure in the Victorian health system since 2019, and this change policy is currently being adopted in New South Wales health facilities. Patients need to have their adrenaline injectors accessible. The anaphylactic episode may have been successfully resolved, but the vulnerability and the risk are still there. That's especially the case if the allergen is unknown. A thoughtful and comprehensive discharge can reduce the risk associated with future episodes of anaphylaxis. We need to send patients home safely. That should include ensuring patients are equipped to recognise an allergic reaction, manage their allergy, and respond to a future event as appropriate to their clinical circumstances. It also means documenting everything for other clinicians who will be involved in the patient's ongoing care. To help with this process, we've produced a discharge checklist and discussion guide. The Anaphylaxis Discharge Checklist and Discussion Guide guides you through the conversation you really need to have with people at risk of anaphylaxis before you send them out into the world. And it's not just a tick box. It's not just if they have an adrenaline injector, but if they know how to use it and when to use it. It's not just if they have the prescription they need, but if they're able to get it filled promptly. It's not only that they have details about who can provide follow-up care, but if they understand how important this is and if any barriers stand in their way. Alongside the Clinical Care Standard and the Discharge Checklist and Discussion Guide, we also have a range of other resources that you may find useful in different situations. Ultimately, what we'd like you to take away from this event today is that people at risk of anaphylaxis are vulnerable. By improving the quality of care we offer, we can keep them safe and save lives. That means always keeping anaphylaxis front of mind. Your readiness to recognise and treat anaphylaxis is critical. If you think you may be looking at anaphylaxis, don't delay, act now. Administer intramuscular adrenaline first line. You can save a life. The National Allergy Strategy has played a key role in improving care for people with allergies and in supporting the development of the Clinical Care Standard. We're going to watch a short video from the National Allergy Strategy.
The National Allergy Strategy, ASCIA, and Allergy and Anaphylaxis Australia are proud to have supported the development of the Acute Anaphylaxis Clinical Care Standard. The National Allergy Strategy is a partnership between ASCIA and Allergy and Anaphylaxis Australia, together representing the peak professional and patient support organisations in Australia. We support and endorse the Acute Clinical Care Standard, which is underpinned by ASCIA's guidelines for the acute management of anaphylaxis. Our hope is that together, ASCIA's guidelines for the acute management of anaphylaxis and the Acute Clinical Care Standard will help improve the management of anaphylaxis, whether it be in a hospital, for example in an emergency department, or in the community by ambulance officers or by general practitioners.
The Acute Anaphylaxis Clinical Care Standard ensures that patients' needs are supported, that they have access to their adrenaline injectors when in hospital. Most importantly, patients are provided with the information and the referrals they need before discharge from hospital. The new discharge checklist will ensure that patients across Australia, no matter what hospital they attend, are provided with the information they need prior to discharge. They will be provided with a prescription for an adrenaline injector and an ASCIA action plan for anaphylaxis. Very importantly, this clinical care standard will connect people that have had anaphylaxis with Allergy and Anaphylaxis Australia. They can then speak to our health educators that can provide support and share information to help them with the daily management of the risk of anaphylaxis whilst they wait to see their doctor.
The Acute Anaphylaxis Clinical Care Standard includes several resources that have been developed by the National Allergy Strategy to help improve the management of anaphylaxis. These include things like an image and a link to an animation that shows correct positioning of the person who is experiencing anaphylaxis, and a link to an animation about how to correctly remove a tick in someone who is tick allergic. On behalf of the National Allergy Strategy, ASCIA, and Allergy and Anaphylaxis Australia, we congratulate the Australian Commission on Safety and Quality in Healthcare for developing this excellent and very important standard.
Thank you, Maria and Prithi, for those words. We sincerely thank the National Allergy Strategy for their support and endorsement. And now I'd like to welcome our panel for today's launch. Our wonderful panel today spans a range of expertise across the care pathway, including acute emergency responders through to follow-up care in the community. Each of these points in the care pathway is vitally important to keeping people safe if they're experiencing or at risk of anaphylaxis. But something we also know, and I'm sure we'll discuss shortly, is that connecting these points of care, joining the dots and communicating clearly with our patients and with each other is also vitally important to keeping people safe. So first up, I'm delighted to have here with me in the studio Dr. Prithi Joshi, a paediatric clinical immunology and allergy specialist who you might recognise from the National Allergy Strategy message. Prithi is a co-chair of the National Allergy Strategy, representing the Australasian Society of Clinical Immunology and Allergy, or ASCIA. Prithi is also a staff specialist at the Department of Allergy and Immunology at the Children's Hospital Westmead. She has an active role in teaching and research, in addition to running a busy practice in clinical allergy and immunology. Welcome, Prithi. Great to have you here with us in the studio. And from the studio here in Sydney to Fiona Stanley Hospital in Perth, I'm pleased to welcome Dr. Peter Lehman. Peter is an emergency and acute medical physician who practices in one of Australia's busiest emergency departments. He's represented the Australian College for Emergency Medicine at the Australian Resuscitation Council for over 10 years. Peter has extensive experience in developing resuscitation guidelines, and he's the current chair of the Recognising and Responding to Acute Deterioration Governance Committee at Fiona Stanley Hospital. Welcome, Peter. And from Melbourne, we're joined by Dr. Joanne Simpson. Joanne is an experienced general practitioner with a special interest in allergic disease. Joanne is a past chair of the Allergic Disease Specific Interest Group of the Royal Australasian College of General Practitioners, and she also holds a graduate certificate in allergic disease from the University of Western Sydney. Welcome, Joanne. Glad you could join us today. And finally, I'm delighted to welcome Adjunct Associate Professor Alan Eade, ASM. Alan is the Chief Paramedic Officer for the Victorian Government, based within Safer Care Victoria, where he was involved in the development of the Safer Care Victoria guidelines for management of anaphylaxis. Alan is an intensive care paramedic with Ambulance Victoria and a volunteer and chair of the National Clinical Governance Committee of St John Ambulance Australia. He's a fellow and past president of the Australasian College of Paramedicine and an adjunct associate professor in the Department of Paramedicine, Monash University. Welcome, Alan. Now, to start our discussion about the acute anaphylaxis clinical care standard and what it will mean in practice, we have a case study of a 10-year-old boy called Jack. So, first of all, Jack, a 10-year-old boy, has been out for a family dinner. After starting his meal, Jack starts wheezing and coughing. His lips look slightly swollen and his voice is hoarse. Jack has an allergy to peanuts and has been prescribed an adrenaline injector. He also has asthma, which has been worse lately, especially at night, when he's been waking up and needing his inhaler. He uses a salbutamol inhaler PRN and has regular inhaled corticosteroid, fluticasone. His parents give him his salbutamol puffer, but he complains it's making his mouth itchy. They're unsure about using the adrenaline injector, as they're careful not to order anything containing nuts. At this point, Jack's parents call an ambulance. So, Alan, I'd like to start with you. As a paramedic, what are the key issues for a first responder?
Thanks very much. Well, first, I'm jealous that they're actually out at a restaurant, being a Melburnian. But in this particular circumstance, I think we need to support people to follow their allergy action plan. And knowing that Jack's been prescribed an auto-injector, he probably has, or he should have, an action plan to go with that. And so in the event that the parents have called identifying that they think that he could be having anaphylaxis, part of the call-taking process is to support people to work through their action plan and determine if this is anaphylaxis, which it certainly sounds like, and to support them in the use of their adrenaline auto-injector prior to arrival of any emergency services. If that hasn't occurred prior to attendance, then it's about supporting the recognition. So does this look like anaphylaxis? And it certainly does from the description. So whilst organising to provide adrenaline by intramuscular means, as you were suggesting, we're also going to take the opportunity to position Jack supine if he's breathing adequately during that process whilst the adrenaline is made ready, so that we can connect the first three parts of the care standard, being recognition, intramuscular administration of adrenaline, and appropriate positioning, right up front. And from there, undertake a more detailed assessment of Jack's needs and an ongoing review and assessment of his clinical condition to make sure that he doesn't need additional doses of adrenaline. Adrenaline being the principal drug that we're going to use to manage anaphylaxis. You mentioned a few other agents that are available, but I'm just going to focus on using adrenaline because there is no other medicine that is more important than the use of adrenaline in the management of anaphylaxis. We've kept Jack flat, or mostly flat, depending on his breathing, because we are aware that people with anaphylaxis can have catastrophic reduction in their blood pressure, and that can have significant impact on their well-being. So once we've managed to stabilise Jack's condition, wherever he happens to be lying now, it's about how we then transfer him onto further medical attention in a safe manner. So we would use, in almost every instance that you could describe, a stretcher to keep him flat while we transferred him out to the ambulance and conveyed him usually to a hospital, so for ongoing care. It is important that people understand and feel comfortable in accessing the emergency services no matter where they are across Australasia, because the ability to manage anaphylaxis and repeatedly provide adrenaline by intramuscular injection is key to patients who have significant anaphylaxis presentations. And so it's very difficult to remain lying flat in a car and to continue to provide care. So calling an ambulance is a very, very important part of any allergy allergy action plan. So there is much that we can do even before the arrival of the paramedics through advice over the telephone. But the very basic approach is the use of the allergy action plan by all of the people who are prescribed auto-injectors, because that can occur before they've even made contact with the emergency services.
Fantastic. Thank you, Alan. Unfortunately, in this case scenario that I'm presenting, that might not be the track that we went down. So, for example, instead of using Jack's adrenaline injector and calling an ambulance, Jack's parents might put him in the car and drive him to ED. And so in this situation, Jack arrives at the ED, and by now he has significant wheeze, coughing, slightly swollen lips and a hoarse voice. He hasn't had adrenaline, only the salbutamol inhaler. He's triaged quickly due to the potential for anaphylaxis, but the RMO who assesses him decides to administer salbutamol via their meter dose inhaler and oral steroids and assesses response before considering adrenaline. Peter, as an emergency physician, what's your view about this decision, and why might it be better to take a different approach?
Yeah, thank you. I mean, let's face it, Alan's initial approach, they could have called an ambulance and it had been brilliantly treated by the paramedics before they arrived, is clearly where we want to be heading with Jack. And it's unfortunate that Jack's now in this situation arrived without any pre-hospital treatment. Clearly recognised as being sick, triaged as priority 2 and brought through to the ED. And the RMO has, at the bedside, made the decision that it's asthma because of the history of asthma and that it's not anaphylaxis, and has gone down an asthma pathway, and this child's now at serious risk. And of course, what we've got with this standard is a statement where if you have any concerns or any features of anaphylaxis, you get immediate adrenaline. And what this RMO needed to have done and needs to do is to give immediate adrenaline. There's no harm in giving this child immediate adrenaline. This child is going to benefit, is going to have their treatment, the right treatment with the early immediate adrenaline. I think what we've used this scenario to highlight probably one of the commonest, if we say misdiagnosis or uncertain diagnosis, which is that asthma, wheezy child with difficulty breathing who may not have had an anaphylactic exposure or allergic exposure. In this situation, there are features there which are consistent with anaphylaxis, or developing anaphylaxis. And we need to have our emergency department staff recognise that, have protocols in place that are based on the standard that allow them, are permissive for them to give early IM adrenaline.
So, Peter, you're in one of the largest hospitals in the Southern Hemisphere. Would that statement still stand if it was a small rural facility, for example, a nurse in an emergency department with an on-call GP VMO?
Yeah, that's look. One of the other things I'm fortunate enough to do is also work. We have a telehealth service in Western Australia, so every nursing post and every rural hospital has access to immediate telehealth advice should they need it. But this is a situation where I would have an expectation that every healthcare facility would have an anaphylaxis management plan for patients presenting, where the nurse is enabled to make a rapid assessment and to give the appropriate treatment, which is the first dose of immediate IM adrenaline, which is weight-based, obviously, for Jack, or an adult dose. And that should be something that every nurse in every healthcare environment is enabled to do, knows where their adrenaline is, and of course could even use the child or the patient's auto-injector if they had no immediate access to adrenaline and there was an auto-injector available. So you're right. I don't think that whether you're in a tertiary hospital or you're coming to a tertiary hospital or whether you're going to a rural nursing post, the initial assessment and the initial treatment is the same. And whichever level of healthcare provider you are, you should have the knowledge to make the diagnosis and the access to the adrenaline to give. And you don't need to ask for a senior opinion. You don't need to seek approval from someone off-site. This is something that not a first responder, but a first responder in a hospital needs to be enabled to do.
Excellent. Thank you very much. So, Prithi, from the clinical immunology specialist perspective, when does an allergic reaction become anaphylaxis?
Okay, thanks, Amanda. Look, I think this actual case of Jack is a really good case in point because, as you can see from his signs, he has developed coughing, wheeze, and a hoarse voice, and maybe slightly swollen lips. So he hasn't got a rash. He hasn't got the urticaria that everyone expects might happen with an allergic reaction, but he's clearly got anaphylaxis. So you may not always have a rash or something that's obviously considered an allergy that signals your anaphylaxis. So what I want to say by this is that it may not be an allergic reaction that becomes anaphylaxis, maybe anaphylaxis presenting straight away. And so this would involve anything that involves the respiratory system, the cardiovascular system, or in the case of an injected allergen, prolonged abdominal pain or vomiting. Those are systemic effects. It's a multi-system disease, anaphylaxis, and adrenaline is the only thing that will treat these multi-system symptoms. Airway symptoms include a staccato cough, wheeze, more obvious things like difficulty breathing, a hoarse voice because that is your upper airway swollen or stridor, a swollen tongue, which can of course obstruct your upper airways, and then cardiovascular, things like feeling dizzy or faint, change in consciousness, and very importantly with a young child that might be pallor and floppiness, and that indicates hypotension. And these things can progress very quickly and become very severe very quickly, and it's important to recognise. And I think Peter said earlier that one of the common misconceptions is this asthma. And he pointed out, and Alan pointed out, you're not going to do any harm even if it is asthma and you've made a mistake somehow with treating with adrenaline. Adrenaline, you'll remember, used to be the treatment for asthma a long time ago. So it is the right thing to do and it will relieve this multi-system response.
Excellent, thank you. So Jack and his parents actually had an adrenaline injector with them, but they hesitated to use it. Joanne, as a GP, you see a lot of people after the event. What are some of the barriers to patients using their injectors?
No, thanks. Look, I think that it's a big step to go from actually being prescribed an EpiPen and having the EpiPen demonstrated to you and practicing at home, maybe on an orange with an expired pen, to actually then using it in an acute setting. And I think that there's many reasons for that, but most of them are based around fear. So there's the fear that they're going to actually use the pen incorrectly, and many people have never given an injectable medication before. There's a fear that they're going to get the diagnosis wrong. So, you know, maybe they're using it at the wrong time in the clinical scenario, or they're going to get, it's not actually anaphylaxis at all. And that fear is often a fear of wasting the time of medical people. So, you know, they don't want to use the EpiPen and then they're going to have to call an ambulance and then they're going to have to go to the hospital. And, oh, of course, the hospitals are very busy and the ambulance people are very busy, particularly in COVID times. And, you know, they don't want to waste people's time. So, you know, I think that it can't be overemphasised how important it is to educate again and again in multiple settings about when to use the EpiPen. It's better to use it than not to use it. And, you know, more harm's going to come from not using it than using it. And that they're quite safe to use it confidently. And it needs to be run through, you know, the scenarios. When are you going to use this pen? Yes, it's okay to use it then. Doesn't matter if you make a mistake and you use it too early. So, you know, I think community pharmacists need to be involved in that. Hospitals need to be involved in it. General practice needs to be involved in it so that it's reinforced multiple times. And then I think people can feel confident using it.
So we shouldn't underestimate the opportunity to reaffirm when people have actually done the right thing and used their adrenaline injector, and actually be really encouraging and supportive.
That's right. And at the hospital setting, you know, that can be reinforced that they've done it correctly and that was the right thing to do. I think that, you know, that goes a long way to making them feel more confident.
Excellent, thank you. So Prithi, one of the statements in the Clinical Care Standard relates to patient positioning. Why is positioning so important?
Yeah, so Amanda, positioning is a key part of the ASCO guidelines as well, which were recently updated. And positioning is vital because we're trying to protect the circulation. So we want the blood flowing to the heart and the head where it's needed. And we continue to hear stories of patient incidents where someone has had an anaphylaxis and perhaps even self-administered adrenaline, but then he stood up to walk perhaps to transport or to another place, and then they collapse. And there are certainly fatalities that have been reported in this incident. So positioning is vitally important. You can't possibly assess yourself whether you are hemodynamically stable if you've suffered an anaphylaxis or if you've just injected self-injected adrenaline. Therefore, lying flat, as Alan has discussed, or cradling a baby horizontally, not holding them upright, is the correct position to have someone. Or if they're having breathing difficulties, they can be sitting up with their legs outstretched, which also aids blood return to the heart and keeps the central circulation flowing. And then hemodynamically assessing the person when they've actually reached medical care will be the next step. So, and the other position I will mention is the left lateral position for a pregnant woman. So that's all really important, and it's a vital part of care of someone who's suffering from anaphylaxis.
Thank you. So, Alan, you mentioned that the patient should be stretchered into the ambulance and the emergency department. What should first responders do in light of the advice in the standard and the ASCIA guidelines?
Absolutely. So I think the very first point is if somebody has used an auto-injector or has called for concern that they are having anaphylaxis, that in part of the initial contact with the individual is that if they're not already lying flat, that we assist them into that position through the ongoing assessment process. Move into the position that is known through the standard to be the safest at the earliest possible opportunity. Commence treatment, use of adrenaline and current and recurrent doses of adrenaline if needed, because at some point you will have to move the person, and it is always going to be safer to move them onto the stretcher or into the ambulance, etc., if they're already responding to the treatment that we've offered them. We have to get people out as a paramedic. We have to pull people out from under a desk or wrapped around a toilet or out of a tent and all sorts of really very difficult to access places. And so the principle is that at some point you may need to be not in the ideal position, but that needs to be for the shortest possible time until you can get them supine or lying down on a stretcher to allow you to then safely convey them from that point onwards through to the hospital for their ongoing care.
Thank you. Peter, what do these recommendations mean in the emergency department? And for example... Yep. You go.
Yeah, it's okay. So you're right. I think in the ED, in the example where he's arrived not in an ambulance but has been brought in by his parents, he's going to be pretty unwell. And I'm not sure how he's even going to get in safely. He's not going to be able to walk in himself. I hope they probably carried him in. He's going to come straight through to a resuscitation area and be laid on a resuscitation stretcher and have appropriate monitoring applied, and obviously the early administration of adrenaline. From a positioning point of view, as you know, we want them flat. Although I think in Jack's case, he may have some quite severe dyspnea because of his wheeze and his lip swelling, and it might be that he's allowed a semi-recumbent position with his legs extended in that situation. We did talk a little bit also about when is it safe post-treatment for Jack to get up and go and use the bathroom. And in our quality standard, we've talked about if after a dose of adrenaline that you should be lying flat for 1 hour, and if you've had multiple doses for up to 4 hours, with the caveat that obviously we would do good cardiovascular stability monitoring to determine when it's safe. So it's a really good reminder to all clinical staff that the risk of cardiovascular collapse is there even after you've had your adrenaline. You're not cured after you've had your IM adrenaline. You're still at risk of cardiovascular collapse, and there are case reports of catastrophic events occurring when the patient's been mobilized too quickly. So it's a constant reminder that we need to keep a very close eye, close monitoring of the patient, do good cardiovascular evaluation, and determine when it's safe for them to actually mobilize. And we don't like to mobilize them fast at all, and minimize that mobilization as much as possible until we're very confident and that there's no cardiovascular risk for that child or adult.
Excellent. So the next issue is about observation time and discharge. Following staff specialist review, Jack was administered a second dose of adrenaline. He's responded really well to his treatment. His wheeze has stopped and his mouth doesn't feel itchy anymore. He's propped up in bed looking at his phone and he's wanting to go home. It's now 2:30 in the morning, 4 hours since his second dose of adrenaline. So, Prithi, based on the ASCIA guidelines, the clinical care standard highlights the importance of adequate observation and observation time. What's the recommended observation time?
Okay, so the observation time, as Peter just mentioned, is 4 hours from the last dose of adrenaline is the minimal recommended observation time. And that's based on a number of factors. Firstly, it just gives time to actually assess the patient, see how they are, and talk through any of the other issues, particularly on discharge, that we'll go into later, I know. But secondly, there is a risk of biphasic reactions. The literature around this is pretty difficult, and reports mention anywhere between 1 to 20% of anaphylaxis episodes will have a biphasic reaction. And unfortunately, there's no really clear consensus in what distinguishes a primary anaphylaxis that will go on to a biphasic reaction versus one that won't. So you just can't make that assessment. So you have to understand that everyone could have a biphasic or a second anaphylaxis response. So it's important to keep on assessing the hemodynamic response, to use that time then to educate the patient, the family, about what to look for as they go home, and to make sure that that patient is really well and well looked after for when they do go home.
Excellent. So Jack is being discharged home. It's the middle of the night. The family are focused on getting home. The ED is at capacity, as it often is. So Peter, how would you ensure safe discharge for Jack in your tertiary emergency department in Perth?
It's interesting, isn't it, that you've said Perth, because we do know that we have some different jurisdictional rules around medication dispensation across Australia. We're very fortunate in WA that we can write authority scripts within the ED, and although I'm no expert on the PBS, certainly the PBS allows a patient to be prescribed 2 auto-injectors if they've received adrenaline in their emergency department attendance. And that's what we do in our tertiary EDs. And they'd have the prescription, but we actually give them the auto-injectors themselves. We have short videos that we can, and information sheets that allow them to, if they've never used one before, which obviously is a certain proportion of patients, to give them some initial education. So they know exactly what they've got and how to use it and when to use it. And I think that's really important as well. So the whole, the standard is around information, around auto-injectors, and around obviously referral to specialist care and specialist follow-up, and how we have to put that all together for every patient, and recognizing that in some institutions, and perhaps more rural or further out environments where they may not have an adequate supply of auto-injectors to give to the patient, that we need to have systems in place to ensure that they can either go to a community pharmacy on the way home to pick one up, or that they can go to one in the morning if there isn't one open at 3 o'clock in the morning somewhere nearby, and ensure that there is a process in place that each hospital or healthcare environment knows where's their local provider, how does this child or this patient access that auto-injector as soon as possible, so they're not wandering around waiting for someone to give them one. They either go home with one in their hand, or they know exactly where they're going to get one the following morning.
Excellent. Thank you. So the Commission has developed a discharge checklist and discussion guide to help emergency departments cover the key issues at discharge and provide some information for patients to take home. This is available in the resources folder in the top of your screen. Joanne, what does a safe discharge mean from your perspective as a GP? Based on your experience, what's your message for your colleagues in the acute setting or the emergency department?
Well, I think firstly, I agree that an EpiPen is needed, and hopefully the patient can come away with that pen, or at least a prescription, and an emphasis being put on that needs to be picked up from a pharmacy or sourced as soon as possible. And And then I think that because the patient is still at risk of anaphylaxis, and so that needs to be conveyed to the patient. And then I think after that, it's reinforcement from the hospital that they did the right thing, that, this was the right thing coming to the hospital, and a need for them to understand how to avoid the allergens and how to manage if they encounter anaphylaxis again on discharge. So all those things need to come from the hospital. And then I think communication with the GP so that we can then close that loop is really important. So checking that you've got the right GP with the patient and their address, if possible, so that it's not a GP from 10 years ago, that the information is faxed to. And if that information can be sent directly to that GP and then also given to the patient. The next step, I think, is just making sure they realise the importance of making an appointment as soon as possible for follow-up with the GP. So, not in 6 weeks' time, but as soon as they possibly can get an appointment. I think that's really important as part of the discharge. And then, in terms of education, we've talked about that a lot already, but again, it's just going through the management again with the patient, because they've often forgotten. They've been in an acute setting, there's a lot of information, it may be the first time they've had anaphylaxis, and they've forgotten everything they've been told, and they're quite fearful and upset. So, once we get into the GP setting, we can go through everything that happened with them and run through what they would do in the same setting again. We can arrange follow-up and referral to an allergy immunologist if they haven't got that already in place, and try and get that in a timely manner. So, often the GP can then advocate to get that referral in process. And we can support them while they're waiting for that. So, there might be quite a lengthy time, particularly in rural settings where they're unable to see an allergist, and the GP needs to keep on reviewing that patient and making sure that everything's been reinforced, and if there are any problems accessing, we can arrange that for them. I think that, again, it's just repetition, education, and making sure that the hospital keeps general practice in the loop is going to make everything safer.
Fantastic, thank you. Prithi, from your perspective, when is immunology review important, and what should people do if they can't readily access an immunologist, as Joanne just mentioned?
Yeah, look, I think anyone that has had an anaphylactic reaction needs an immunology review. So I say that categorically across the board. I think that's really important. But it is really a problem that there might not be ready access to a clinical immunologist, allergist. So I think in the meantime, while they're waiting, it's really important that they're discharged from wherever they've been, either with the trigger identified or at least some idea of what might have caused that allergic reaction, so they can avoid the trigger if possible, sometimes not always possible. And then reinforcement of the anaphylaxis education plan that they've got to make sure next time they have an anaphylaxis, they can follow that plan, and of course access to the emergency medication. And referral back to the GP, the correct GP, as Joanne has said, is vitally important, because that's a great point of contact and a point of reassurance for them. In addressing the long waiting list, and that could be another whole panel discussion, I feel, what I will say is that, again, GPs are a great point of contact, but if there is no readily available appointment in your area, or might be regional, certainly the closest teaching hospital that has an allergy and immunology department will have an immunologist on call, and there will be a method of accessing them to ask questions, and the GP might do that, or another health professional, and certainly then that patient will be prioritised to get an appointment. And telehealth is a great resource, particularly in this in this setting now for regional people, and that could be the initial consult with that specialist. And then there are, of course, other resources available as well while you're waiting. So from the National Allergy Strategy, from ASCIA, and Allergy and Anaphylaxis Australia, which is a great patient support organisation that has resources and will also help to alleviate some of that anxiety that we've been talking about around this event.
Excellent, thank you. The last thing I want to cover is about access to personal adrenaline. 6 months later, Jack and his family have been doing really well at managing his allergy, and they're avoiding foods containing peanuts. He's been carrying his adrenaline injector everywhere, and his whole family is a lot more confident about using it because they've spent a lot of time with Joanne talking it through. Unfortunately, poor old Jack is not having a good run of luck though, and he's developed appendicitis and he's admitted to hospital. According to this clinical care standard, Jack will be allowed to have his adrenaline injector accessible at all times and within easy reach for his parents to administer if needed. Safer Care Victoria developed a statewide standard for anaphylaxis, which included access to adrenaline, launched in 2019. Alan, could I ask you what prompted this and what was involved in making this change for Victorian hospitals and health services?
This was prompted, unfortunately, out of a tragic case. So there's somebody where a patient admitted to hospital, in fact more than one, was relieved of their personal prescribed medicine, being one of those being an auto-injector, and had an episode of food-based anaphylaxis to the food they consumed within a health service. And there was a delay to their care, and unfortunately this patient died. So this is purely about keeping patients as safe as possible. They're prescribed an auto-injector, they have an allergy action plan, they should be as safe in their community, in a health service as they are in the community. So if we encourage them to keep control of their auto-injector in the community, then we took exactly the same approach across the Victorian health system, and said that there should be no difference in that safety net that people are afforded. And so whether it's within a hospital, whether you're going for a day procedure, whether you're going to the general practice, or whether you're in the back of an ambulance, the patient should retain control and access to their auto-injector, so that they can treat themselves in the event that they believe that they're having an episode of anaphylaxis.
Thank you. Prithi, Jack's not in hospital for his allergy, but he has an allergy. So what should happen about his allergy and his injector during his hospital stay?
Yeah, and Jack's only 10, we'll bear in mind, so he may not be one who keeps his auto-injector on himself, but it certainly should be his proxies, so his parents or whoever's caring for him. So his allergy should be flagged in all the records, and appropriate food should be provided for him, and everyone across the board, from the person who's taking food orders to the person who's bringing the tray to him, should know all about that, and also how to recognise anaphylaxis. His auto-injector, as I said, should stay with whoever's caring for him, because they've been educated in the recognition and management of anaphylaxis. And the problem is in hospitals that ideally it would be great for everyone to respond really quickly, but the process is such that by the time that anaphylaxis might be identified and then relayed to a nurse, who then may have to ask a doctor to review and then to prescribe adrenaline, it may be too late. And that's not what would happen if you were out on the street and you had an anaphylaxis. You'd be able to use your auto-injector. So hospitals do need their own process to make sure that injectable adrenaline is readily available and immediately available, so chartered perhaps PRN for that particular patient. And also all staff need to be trained in how to use that adrenaline and when to use it. So that should be part of hospital protocols as well. So really ready access to adrenaline on the ward is the basic principle.
Excellent, thank you. So I want to bring the panel discussion to a close, but I want to finish with the most important part of the standard from each of your perspectives and why. So I'm going to ask each of our panellists what their takeaway message is for all of the people attending this webinar. So Alan, I'll start with our first responder. What's your takeaway message?
If in doubt, treat as anaphylaxis. Adrenaline is absolutely your friend and is the mainstay of treatment for anaphylaxis, and it will help if you are treating asthma as well. So if you have any doubt, consider it to be anaphylaxis and treat with adrenaline.
Thank you. Joanne, what's your takeaway message?
Look, my takeaway message is really just that, this chain of communication between all aspects of the health system is crucially important in care for people who have had anaphylaxis.
Thank you. Peter, your takeaway message.
It's very similar to Alan, really. Adrenaline is a safe drug when you're concerned about a patient. Don't be fearful of it. We need guidelines, protocols that are permissive to allow any healthcare provider to give immediate adrenaline to any suspected anaphylaxis.
Thank you. And Prithi?
I'm afraid we're all singing from the same song sheet, which is that adrenaline is the treatment of choice for anaphylaxis, and also for people in the community. Use your ASCIA action plan, follow what it says on that, use your adrenaline if you even think it might be anaphylaxis.
Excellent. So thank you so much to all of our panel members for that discussion. Now, to officially launch the Acute Anaphylaxis Clinical Care Standard, we're joined by Professor Willis Marshall, Board Chair for the Australian Commission on Safety and Quality in Healthcare.
As Chair of the Australian Commission on Safety and Quality in Healthcare Board, I would like to thank you all for joining us today. I'm very pleased to officially launch the Acute Anaphylaxis Clinical Care Standard. In 2019, the Minister for Health, the Honourable Greg Hunt, initiated a parliamentary inquiry into allergies and anaphylaxis. The final report of the inquiry, titled Walking Allergy Tightrope, highlighted the need for a consistent national framework for patients who experience anaphylaxis. This new national standard, delivered by the Commission, will help to achieve that consistency across Australia and ensure best practice care. People with allergies that cause anaphylaxis must be constantly vigilant about their safety, with all of the personal and lifestyle changes that entails. As a healthcare community, we must also be vigilant about keeping patients safe. Firstly, in our protocols for recognising and responding to anaphylaxis, but also by ensuring clear communication across the healthcare pathway, especially at transition of care such as hospital discharge after anaphylaxis. I would like to thank all of the clinicians and consumers who have contributed to the development of this important standard, especially our panel members. Their expertise and experience have been invaluable. I hope you have enjoyed the webcast and find the resources valuable. Thank you for again joining us today.
Thank you, Professor Marshall. As our webcast draws to a close, I'd like to sincerely thank our panellists for sharing their time and expertise. Professor Alan Eade, Dr. Joanne Simpson, Dr. Peter Lehman, and Dr. Prithi Joshi. Thank you so much for joining us today. I'd also like to thank the clinicians, consumers, and policymakers who've helped us to develop this standard. I'm sure that there are many of you online who contributed feedback during our development processes and consultation. Thank you so much. There are many pieces to the puzzle, and your feedback helps us to see the big picture and understand the clinical care standard from your perspective. Finally, thank you, our audience, for joining us to learn more about this important new standard. I hope you found it informative, and I invite you to respond to the short survey at the end of this webcast. I also invite you all to explore the clinical care standard and all the resources on the Commission's website. Thanks again. Good afternoon.